Welcome everyone to the EHJ today at the Cardiology update in Davos. It is a pleasure to talk to you today. My name is Alberico Catapano and I'm today taking advantage of the presence here in Davos of one of the leaders in the cardiovascular prevention, actually the person who chaired the Guideline Prevention Committee, Professor Massimo Piepoli, who is very much welcome to participate into this meeting. So Massimo, today we're going to talk about the prevention guidelines. Would you like to summarize the spirit of those guidelines for our audience?
Thank you, Alberico. I've had the honor to chair the 6th Joint Task Force, European Task Force on Cardiovascular Disease Prevention in Clinical Practice, which joined the 10 European society dealing with cardiovascular prevention. I had the honor to chair together with a specialist in primary care, physician, together with a specialist in hypertension, atherosclerosis, diabetes, sports medicine, nurses, psychologists, exercise physiologists, all to cover all the spectrum of cardiovascular disease prevention. We had the opportunity to revise update the new European guideline, which were previously presented 4 years ago in 2012. Our aim was specifically to update and to increase the sensitivity and the general population in Europe concerning the importance of prevention.
Would you like, please, to summarize for us what has been the novelty there? What is different from the previous one, and what has been steady still, if you wish, in these guidelines?
Well, in the guideline, we aimed specifically not to increase too much the length of the document, which was really encyclopedic, the previous version. And we partially reached this target. And also, we focused, following the spirit that WHO has pointed out, a call for action towards intervention in the population level on the major cardiovascular risk factor. We revised and put for the first time in the European guideline indication of intervention at the population level, specifically on the leading cardiovascular risk factor. I'm talking about smoking cessation, alcohol abuse, diet, healthy lifestyle, and physical activity. This has been a novel issue that the task force agreed would be a major impact. We kept, of course, which at the center stage, the importance of dealing at the specific intervention at the individual level on the key factors in cardiovascular prevention, mainly hypertension, diabetes, atherosclerosis, and sedentary. And of course, also we included also aspects related to disease-specific intervention on leading entities like atrial fibrillation, coronary artery disease, heart failure, peripheral artery disease, and cerebrovascular disease. We also consider highly the importance of prevention at some specific subgroup of people, like younger, which we felt sometimes can be at a low absolute risk, but this can be hidden by a very high risk, uncontrolled risk. Women, which are often neglected in our studies, and aging as well, which we pointed out the importance of be wise concerning the intervention, and also some other people, other subgroup people like immigrant, that we unfortunately don't know exactly how to stratify, how to recognize, identify their risk.
There's been a lot of discussion about, in primary prevention, about how to address the risk, how to calculate the risk. With the scoring system that has been adopted widely in the guidelines, also the Lipid or hypertension guidelines. Do you have any idea what we should look forward to, or what can be modulated in this scoring system in order to make it more contemporary?
This has been an important issue that you are raising. The task force agreed that a score system is crucial, is important, because it allows the primary physician, but also as cardiologist, to identify, correctly stratify the patients. We know that only 24% of physicians are able to correctly identify the risk of individuals, and using scoring system allow us to follow better guideline and to increase outcome in our patients. There are several scoring systems which are being with different outcomes, with different indicators. The task force kept traditionally the score system, but we know that there are several others, and we know that this can be reconsidered in the future, whether it should be updated or improved in the future.
Another point of importance in these guidelines has been how you address some other factors that are becoming more and more important, like adherence to lifestyle changes and therapy. Is there anything new under this area in the guidelines?
Yeah, this has been an important aspect of the intervention of behavior medicine, or to improve adherence to the treatment. And we focused also our attention whether there is any news about importance of to improve this important aspect of our population, that we know that on long-term adherence is quite poor, also in the best clinical practice. We consider highly also the importance whether new approach like polypills can be used, and this has been considered also in the new guideline.
There is another point that in previous guidelines has made some difficulties in understanding among colleagues out there. There was some discrepancies between the global or prevention guidelines and the specific guidelines, for instance, hypertension or lipid guideline. Has that been taken care of now?
This has been at the central stage of our task force in order to keep absolutely on the same track, on the same recommendation. For example, the atherosclerosis guideline, lipid guideline, because we had the opportunity to have the chair of the lipid guideline together working with us, and my co-chair was also in the board of the lipid guideline. This was important because as a European society we aimed absolutely to give a unique information and not misleading. As well as also the hypertension guideline, we aimed absolutely to be consistent with the specific guideline.
One last question before we close. There has always been a time for revision of the guidelines that usually is 3 to 4 years. Now, what is the position if something new, really important, comes in, let's say, in a few months? Will that be something that will trigger adjustments to the guidelines, or we shall wait for next 3 years before seeing something incorporated into the guidelines?
This is very crucial, a key question. When one guideline is published, we know that something new is always coming, especially at the last moment, and also in the near future. We, as a task force, of course, has to consider heavily what the news is published, and considering also what is the reaction, and then about the scientific committee, and this, of course, will be taken into consideration in the revision of the guideline in the future.
So, thank you very much, Massimo, for participating in this discussion, and I hope the discussion we had will be useful to you participants. And again, we're coming now to the end. Thank you very much for participating here.
Thank you, Alberico.